Right, thank you, and thank you for the opportunity to talk to you this afternoon about hematopoietic stem cell transplantation in aggressive multiple sclerosis. So, as you see, I'm a hematologist, not a neurologist. So my knowledge of MS when I first started in this area was limited to what I learned as a medical student and in my early training. But it's been an interesting journey along the way. I have been doing stem cell transplantation for MS since 2009, did my first transplant. And interesting, as Dr. Rashid just talked about, the heterogeneity of MS. The first patient I did had an EDSS of 8.5 when I did that patient in 2009. We would not do that patient now because we would think it's too advanced and the data doesn't support it. I saw that patient 3 months ago in my clinic, still 8.5, and has not progressed. And if you believe the trajectories, he would be dead by now. So it just goes to show we don't know everything about how MS works in patients. And therein lies some of the complications. What I hope to give you this afternoon is a relatively balanced view of HSCT. And again, for those of you who read the forums and read some of the literature out there, there's a lot of hype around HSCT, and we need to take a balanced view. It is still early days of understanding how it works and what's the best way to treat patients. But what I hope to do this afternoon is talk to you a little bit about what HSCT actually is, because again, a lot of people don't understand what the process involves. So we'll go a little bit through how we perform HSCT and some of the risks and complications, because this is a procedure that does have risks, and we'll talk through some of those. And again, the long-term follow-up of patients and what happens to them down the line. So I'm not going to go over what's already been discussed, but just to say that despite all the ever-increasing list of treatment options, we still are unable, in most patients, to halt progression of MS. It still does progress, even though maybe at a slower rate with some of the newer treatments. So what is HSCT? There is increasing evidence of efficacy for HSCT, and there have been some really interesting publications in the last 2 to 3 years, and this is why interest, I think, amongst the neurology community has increased, because for a long time there wasn't any real publications of people doing HSCT. Like I said, I did my first one in 2009, but certainly in Europe they had been done long before that. But there were no real good publications until the last 2 or 3 years showing some evidence for benefit of HSCT. And these are the list of publications, and the most recent one is the one that came out earlier this year, which was an interesting publication because it's a retrospective analysis of over 280 patients throughout Europe who'd had HSCT, and some of them were much more progressive, and the average EDSS was up to about 6. And it showed again, and even in that group of patients who historically you would say shouldn't really have HSCT, there was some evidence of slowing and of progression of their disease. So the aim of HSCT is to try and reset the immune system. So rather than just try and dampen down the inflammatory damage or dampen down the immune dysregulation, which is what a lot of the current therapies do, what we're really trying to do with HSCT, if done correctly, is to try and reset the immune system. And there is some in vitro data in publications that have been done previously to suggest that you can reset the immune system with HSCT, and you can induce a relatively naive immune system using stem cells. Now, this is important if you believe that HSCT is primarily an autoimmune disease. So if you believe that the immune system is at fault and is damaging the nerves on an ongoing basis, then if you can reset the immune system, then potentially you may be able to halt further damage. Wherever you can reverse damage is more difficult to predict, and HSCT doesn't really reverse damage. What it does is halt further progression. If you get it early, then you may get improvement because the body's ability to repair damage that's already been done, if it's limited, is much greater than if the damage is extensive. Again, on the net and on the forums, you'll hear lots of talk about stem cells, and it's important to understand that when we talk about stem cells, it can mean many different things to many different people. What I'm talking about here, in the context that I use them in, is hematopoietic stem cells. These are stem cells that have the ability to regenerate the blood and the immune system. They are not cells that regrow nerves or any of those things. Those are different types of stem cells. And people are using those stem cells. Some centers around the world are offering injections of neural stem cells, and these are all experimental therapies, and you need to be very cautious when you talk about stem cells about what exactly you're talking about. So HSCT is simply a way of resetting the immune system in the context of autoimmune disease. Now, as a hematologist, I've been using HSCT for a long time for treatments of blood cancers, because what we're doing in HSCT in that context, we're not worrying so much about the immune system. What we're worrying about is getting a bigger dose of chemotherapy into the patient so we can cure them of their blood cancer. So it's a very different context I've been using it in. But in this context of autoimmune disorders, I'm more interested in what it's doing to the immune system. And what we're trying to generate is what we call a naive T-cell repertoire. If you look at the immune system in an MS patient, it is skewed. It is not a normal distribution of immune response. After the transplant, what you're hoping to see is a much more normal distribution. You'll also hear in the literature a lot around myeloablative and non-myeloablative transplants. What that simply means, myeloablative means that you're giving a dose intensity of treatment, chemotherapy, such that if you were not to give stem cells, the bone marrow would not recover. Whereas non-myeloablative means you're giving an intensity which, even if you didn't give the stem cells, the bone marrow would ultimately recover. It may take a while, but it will recover. And my belief is that you need to be going much more towards the myeloablative end to really reset the immune system. What the sweet spot is of how intensive the regimen needs to be is unclear. No one knows. If you look at all the data so far, there is no convincing evidence that one regimen is superior to the other, but there is a suggestion in some of the latest trials that the more intensive regimens have a longer lasting response than some of the less intensive regimens that are being used. So how do we perform a transplant? You'll again see on the forums a lot of jargon around transplantation. I'd like to break it up into three phases. The first is the mobilization. So mobilization simply means we're mobilizing the stem cells. So stem cells are normally found in the bone marrow. In the old days, we used to do what we call bone marrow transplants, because we should just go in through the back of the pelvis, suck out a litre of bone marrow, and that would have enough stem cells in to do a transplant. What we can now do is mobilize those stem cells to come out into the blood, where we can collect them a bit like a kidney dialysis machine, where the blood goes out, collect the stem cells, and blood goes back. In order to mobilize them, you need to give a bit of chemotherapy or an injection called GCSF, which just stimulates the bone marrow to produce more stem cells. Once you've collected the stem cells, you can freeze them and you can store them for years. The second stage is the actual HSCT procedure itself, and that's broken down into two stages. One is the conditioning regimen, which is basically the treatment you give to get rid of the immune system. So again, it varies from hospital to hospital. The UK has a particular regimen of choice. Other centres around Europe and in different parts of the world will do slightly different conditioning regimen. Nobody really knows what's the best way to go. And then once you're given that 6 days, in our case in the UK, of treatment, you then reinfuse the stem cells like a blood transfusion back into the arm. The stem cells like to be in the bone marrow, so they find their way back to the bone marrow and then start to divide and grow and replace the blood system and the immune system. But it takes about 2 to 3 weeks. And that's the time when the patient's at most risk and is in hospital. So I've talked about source of stem cells. We use a particular regimen, a combination of chemotherapy and GCSF injections to stimulate the bone marrow to produce the stem cells, release them into the blood and collect them. I believe that that's an effective regimen because we get a good stem cell dose, and also that chemotherapy gets rid of some of the immune system. The risk is you contaminate the cells you collect with some cells of the mature immune system you're trying to get rid of. Other centers do it differently, and the Mexico system is different, the Russian system is different, but this is the one we use in the UK. So this is just a graphic showing you how it all works. We mobilize the stem cells, we then preserve those, we freeze them in liquid nitrogen. They need to be frozen in liquid nitrogen so they don't die. And then we then give the patient the conditioning regimen. We then reinfuse the stem cells back. We then wait until they grow. That's roughly about 3 weeks. And then the patient goes into, can be discharged and go into post-transplant follow-up and recovery. The conditioning regimen we use is a big dose of cyclophosphamide. That's 200 milligrams per kilogram, so that for most people is 15 to 20 grams of cyclophosphamide in one go. That's a very big dose of chemotherapy. And we also give this antibody called ATG, anti-thymocyte globulin. That removes a specific component of the immune system, the T cells, out of the body. And that's given over 6 days for the patient. What are the toxicities of transplantation? Early on, patients get fever with ATG. Because it's a rabbit product, you react to it like you might react to a blood transfusion. So you can get a fever, you can get a skin rash, and sometimes, worst case scenario, you can get anaphylaxis. What we didn't realize when we first started doing these transplants was that MS patients tolerate fever very, very badly, particularly ATG fever. And, we used to, in hematology setting, we would just give patients antibiotics and off they go. MS patients, we need to get that fever down quickly because if you don't, they decondition neurologically. And it's probably something to do with the blood-brain barrier. So now we give steroids at the same time because we want to get that fever down very quickly. So the kind of doses of chemotherapy that we're giving almost certainly affects the bone marrow because that's what you're trying to do, empty the bone marrow and then allow it to regrow with the stem cells. But it will have toxicity on other organs as well. It will have gut toxicity. So patients will get diarrhea, patients will get mouth ulcers, patients will get really severe dysphagia. They can't swallow because the whole lining of the gut has been denuded by the chemotherapy. They can get liver damage, kidney damage, lung damage. It's important that we do a full physical assessment of patients before we put them through this procedure. The main risk to patients is, however, marrow toxicity. So the blood counts drop, so the red cells drop, the white cells drop, and the platelets drop. So they bleed because the platelets are low, and platelets are important to stop you bleeding when you cut yourself. They become anemic and very tired, and most seriously, if the white cells are dropping, the risk of infection is very high. And so they're in isolation for a significant proportion of this time. And this is where the mortality of transplantation comes from. It's normally infection related. And those are the cells of the immune system and your your defense against infection. So the neutrophil count is the one that drops most precipitously early, and that's the one that recovers around about 2 to 3 weeks later. That's the one that keeps people in hospital in isolation. The other bits of the immune system take a while to recover. NK cells come back a little bit quicker. T cells might take 18 months to recover after this procedure. So patients can still get viral infections 6 months, 12 months, 18 months after the transplant. You still need to keep an eye on them. So what's the experience so far of transplantation for MS? Well, it's increasing. And people think, well, it's very rare, nobody really does it. But actually, well over 2,000 transplants across the world have been done for MS. So we've got quite a big body of knowledge now about transplants. But what we're knowing is that most centres only do a few. So most centres will only done a handful of transplants. You can see there's 114 centres in 27 countries that did that 800 transplants. So most centres don't have a huge amount of experience. This is showing you the international league table for numbers of transplants done for MS. In UK, having been historically very, very slow to take this procedure up, it was mainly led by the Italians, to be honest, and then the Germans. But the UK is now moving up that league table very, very rapidly, and I'll show you some data about the number of transplants we're doing in the UK. In Sweden, it's now fully funded by the NHS, their equivalent of the NHS. HSCT is now recognised as a treatment option for MS. Important thing to note on this slide is this is transplant-related mortality at 100 days. So this is showing what is the factors that might determine what patients don't do well or die through the procedure. And the number one factor was centre experience. So those centres that had done less than 13 autoimmune transplants did worse than those centres that had more experience. And that's because it's a learning curve for haematologists like myself. When you're transplanting patients with autoimmune disease, it's very different from transplanting someone with leukemia. There's a lot more to think about because leukemia patients have a single organ failure. Their bone marrow has failed because of leukemia. That's all you're dealing with. In an autoimmune disorder, you might be dealing with somebody who's got heart problems, neurological problems in MS, joint problems, kidney problems. So it's a much more complex transplant. This again is showing year on year the increase in transplants done across Europe, and you can see really over the last 2 to 3 years it's really taken off. So the awareness and the utilisation of HSCT for MS has really increased. And this is our own local data in London showing it hasn't even got my first transplant, which was, I did one in 2009 and didn't get another referral for 2 years. But you can see now, in 2016, the Hammersmith Hospital started doing it. I'm doing them at King's College London. But the numbers are going up, and now we've got a waiting list from having had no patients coming through the system. We now have got patients backed up because there's so many coming through. We just had our MDT yesterday to discuss patients for transplant, and we had another 25 patients to discuss who are potential candidates. This is probably the slide that is probably most controversial, the next set of slides, because we've had to come up with some criteria for who we believe should have HSCT, because it's not for everyone. And these criteria we have based on the best available clinical evidence. And it's important to say that, there will be some patients who we say no to who may still benefit from HSCT. What we're basing on is a majority situation. So we have to draw the line somewhere. So what we're basing our decisions on is where the most evidence sits. But we recognize that some patients may go off somewhere and have their transplant and say it worked for me. But we have to set the criteria somewhere. The NHS will fund transplants for MS if it is agreed criteria. And what we didn't want to do is to open the floodgates where suddenly we were transplanting patients where we wouldn't get benefit, and the NHS would just stop funding it, and then nobody would get a transplant. So we had to draw the line somewhere, and we did it based on published evidence. So this is the criteria where the evidence sits best. So the 65-year age limit is purely down to haematology. So that's our criteria, because above the age of 65, most people don't tolerate this type of procedure. It's too toxic. So the age criteria for 65 is not around the MS, it's more around the haematology fitness for the transplant. Disease duration should be less than 15 years. That's the most evidence is that the disease duration less than 15 years, there may be some benefit. The McDonald criteria, which is just, as Dr. Rashid's talked about, it's just been revised, but they need to be obviously diagnosed with MS. If they're primary progressive MS, we will do them. And we've started taking on primary progressive MS in the last